Good morning, good afternoon, good evening, everyone. I think we'll go ahead and get started even as people are continuing to join our virtual symposium. My name is Satish Gopal. I direct the Center for Global Health at the United States National Cancer Institute, and I'm thrilled to welcome all of you today and to officially open the 10th Annual Symposium on Global Cancer Research, which we'll be holding today and tomorrow, and to welcome you on behalf of the National Cancer Institute. As many of you know, and as with prior years, this is a meeting that we host with a number of critical institutional partners, including the American Association for Cancer Research, the American Society for Clinical Oncology, City of Hope Cancer Center, the Consortium of Universities for Global Health, Instituto Leloir, Fundación, Partners in Hope, the UCLA Jonsson Comprehensive Cancer Center, the Republic of Zambia Ministry of Health, and the USC Norris Comprehensive Cancer Center. I hope all of you have had a chance to view the really, I think, touching welcome videos recorded by leaders across these various institutional participants that are featured on the conference website, as well as on our NCI Center for Global Health social media account. I also want to thank the organizing committee members from each of these organizations that have really been critical in developing the program for this year's meeting, which I think is tremendously exciting and hopefully which you all will really enjoy over the next couple of days. Next slide, please. So this is a virtual symposium, and I think we have tried to fully embrace that format. So just to get a few logistical reminders out of the way at the beginning. I think previous slide, yep. So attendees will be muted throughout the event. This symposium will be recorded and is available on the symposium event site. As a reminder, last year's symposium, which was really successful, is also recorded and available for those of you who are interested in viewing this on our website. For any audio or video issues, please refer to the Zoom Help Center. The link for that is shown here on this slide. If you find that you're able to see a slide but can't hear anything, do check your audio settings. You may have to connect to the audio via computer or dial into the session using the local numbers that are provided in the webinar information that was emailed to you. Questions, please submit those using the Q&A box. Next slide, please. So we've wanted to really embrace this as a virtual symposium and intend to do that going forward, because one of the things that we've been thrilled about is the way in which this allows inclusive participation, particularly from investigators and people working in cancer research and control in LMICs who often aren't able to participate in the cancer research enterprise. At the same time, we've tried to make this virtual meeting as interactive as possible. And one of the ways that we've done that is using this Mentimeter tool. So during the scientific panel discussions, the facilitators will post a Mentimeter question on the Zoom screen, and this is really intended to allow us to engage the audience and hear feedback from them during the course of a session. This has worked very well for us in previous meetings, including last year's symposium. So what you will do as an attendee is open a browser on your computer or phone and type in www.menti.com. There will be a code that's on the Zoom screen, and you enter that and submit it, and then this will give you the opportunity to respond to the question that's being posed, and that information will be integrated and synthesized in real time, allowing us as speakers and facilitators to respond directly to audience participation and feedback. All responses are anonymous, and again, we have found this to be a really valuable tool for making these virtual meetings as inclusive, but still as engaging as possible. Next slide, please. Join us on Twitter. So we've tried to highlight, I think, the lead up to this meeting throughout the weeks and months that have preceded today's opening. You can follow us at the NCI Center for Global Health at NCI Global Health and engage with us on Twitter using the hashtags ASGCR22 or ASGCR 2022. There was a fairly vibrant social media discourse yesterday featuring an early career investigator day that we did for the first time, and I'd encourage all of you to participate and engage with us during these 2 days and subsequently on social media. Next slide, please. So I'm one of the symposium hosts and delighted to be participating in this way together with Drs. Karina Musharod and Dr. Sam Piri. They will be joining and helping to close day 1 and then open day 2 tomorrow from Lilongwe, Malawi, where they're actually together. And so thanks to them for helping to host, which really will just be opening and closing each day's session and facilitating that. Next slide, please. This is our agenda for the first day today. So we're nearly to the end of my opening remarks. Then we'll proceed to an oral abstract flash talk session featuring some of the highest rated abstracts that were submitted for this year's meeting. Following that, we'll have a Meet the Abstract Authors and interactive poster session that we'll be conducting using GatherTown, and more details about that to follow. Then a scientific panel focused on systems thinking applied to global cancer research that I think has been really wonderful to see that come together in recent weeks and months. And then we'll have day 1 closing remarks by Drs. Mouchereau and Piri. Next slide, please. I wanted to acknowledge that this is the 10th annual Symposium on Global Cancer Research, but the first without Paul Farmer living amongst us in the world. And I thought that was important to note given the enormous influence that he's had on many of us as individuals, and I think our field that we all work in. And so I thought it was important just to mention this at the outset. I did want to highlight one of the things that Dr. Farmer is famous for having said at various points throughout his long and distinguished career, which is the idea that some lives matter less is the root of all that is wrong with the world. And even though Paul won't be participating with us this year as a live participant, but rather in spirit, Professor Agnes Binagwaho will be participating as a live participant and is actually moderating one of our sessions tomorrow, which we're tremendously excited about. And I saw somewhere that she said in remembering Paul recently that the best way to honor his memory will be for all of us to stand stronger together, doing what he loved most, which is fighting poverty and disease, promoting human dignity with a focus on the most vulnerable, and promoting equity. So to me, that's what this meeting and this community is really all about. We're thrilled to have been inspired and influenced by people like Paul Farmer and Agnes Binagwaho, and will really encourage us as we initiate this year's symposium to keep these ideas in mind in the discussions that we have and all of the work that we'll do subsequently. Next slide, please. So with that, I'll turn over to the oral abstract flash talk session, which will be led by Alison Frank and Webster Musonda. And again, thank you all for joining this year, and really excited about the discussions that we'll have and the work that will be presented over the subsequent 2 days. Thank you.
Thank you. Hello to all attendants from across the globe. I would like to welcome you to this year's Scientific Abstract Oral Rapid Fire Session. My name is Webster Musonda. I'm a postdoctoral fellow at the Beckman's Research Institute at City of Hope National Medical Center in California. So I will be co-chairing this session with my colleague to be introduced. Yeah, so the purpose of this session is to provide opportunities for a diversity of researchers to present and disseminate their global cancer work to pertinent stakeholders. And this has become a foundational piece of each annual symposium on global cancer research. So the NCI's Center for Global Health has partnered with the American Society of Clinical Oncology and the American Association for Cancer Research to allow for all abstracts selected to be published each year as part of a special supplement for this meeting. So the 10 oral abstract presentations to be presented during this session were selected in a peer review process based on overall score and relevance to the priority topic areas and relevance to the theme of new models for global cancer research, training and control. As you may be aware, this is the theme for this year's symposium. So the presentations have been grouped into 5 topic areas along the cancer and control continuum, and these include biology, prevention, early detection, treatment, and cancer control. So these are high-level rapid-fire presentations, and additional study-related details are available in the poster presentations. The links for these will be shared. This is in the chat and at the end of the session. So please note that there will be no Q&A session. Instead, we encourage you all to find these presenters during the Meet the Abstract Authors Interactive poster session following this session and tomorrow. There will be an interactive discussion with these presenters, as well as the more than 60 other authors that submitted their abstracts at the Meet the Authors session in Galatown today and tomorrow. You can find full list of accepted abstracts on the event webpage under the poster tab. So without further ado, please allow me to hand you over to my colleague to begin this session. Thank you all for your attention.
Thank you, Dr. Masanda, for that great introduction. I'm Allison Frank, and I'm a Cancer Research Training Award Fellow at the National Cancer Institute Center for Global Health. I'm really excited to begin the session with a presentation on the topic of biology from Dr. Maria Sol Ruiz. Next slide.
Good morning. Thank you for the opportunity to present our work today. My name is Maria Sol Ruiz. Next slide, please. We are studying acute lymphoblastic leukemia, which is the most common cancer in children. The improvements in the treatment of this disease have resulted in high overall survival rates. However, relapse is the most important cause for treatment failure and death. The aim of our study was to identify molecular profiles in leukemic cells and in the bone marrow microenvironment that can help better predict disease outcome. For this, we collected bone marrow samples from pediatric patients at diagnosis that were treated in 3 hospitals in Argentina and were part of a national clinical protocol. We performed transcriptome sequencing, and with this data, we searched for differentially expressed genes. We also focused on long non-coding RNAs. We looked for sequence variants and chimeric transcripts in clinically relevant genes, and we profiled immune populations at the tumor. After this, we performed association studies of all these molecular features with clinical parameters. Next slide, please. What we could observe in the first place was a differential activation of molecular pathways among patients that were classified as a standard, intermediate, or high-risk group. And these pathways were related to signal transduction, DNA replication, and the immune system. Secondly, when we focus on the long non-coding RNAs, we could observe that the expression profile of differentially expressed long non-coding RNAs was able to cluster the majority of high-risk patients. Therefore, we are currently studying the biological significance of these molecules by performing, for example, correlation analysis with significantly altered pathways. In the third place, we could identify sequence variants and chimeric transcripts in 44% of patients after applying a filtering and annotation pipeline on more than 9,000 variants. And we observed that the group of patients with at least one mutation in these genes had a lower relapse-free survival, suggesting that the assessment of mutations in these genes at diagnosis could be of clinical interest. Next slide, please. We perform also an immune profiling of the tumor microenvironment. For this, we first apply a deconvolution tool called Mixture to estimate the proportions of immune populations using bulk gene expression data. This allowed us to cluster patients according to the immune profile in the bone marrow, and we are performing associations of these clusters with clinical parameters. Additionally, we estimated a cytolytic score based on the expression of 5 genes specific of cytotoxic cells, such as CD8 T cells and natural killer cells, and this score was highly correlated with the proportions estimated by mixture. We also could identify a group of patients with higher levels of cytotoxic cells that showed a marginal decrease in event-free survival and that were enriched in multiple gene sets related to CD8 T cell activation, leukocyte migration, signaling in the bone marrow niche, suggesting an immunogenic microenvironment that could be of potential interest for immunotherapies. Next slide, please. We can conclude that transcriptomic sequencing allowed us to integrate multiple molecular features that might improve classification of pediatric ALL. All the associations that we observed warrant further analysis after a longer follow-up and validation in a larger number of patients. And finally, this is the first comprehensive analysis of the molecular landscape and its association with clinical parameters in pediatric ALL patients from Argentina. Thank you for your attention.
Thank you, Dr. Sol Ruiz, for a great presentation. We're now going to move on. We're now going to move on to the second topic area, prevention. We'll now hear from Dr. Bowie. Next slide.
Hello, everyone. My name is Tan Bui, and I'm an assistant professor at the University of Oklahoma Health Science Center. We have an NCI-funded project, and we partner with the Ministry of Health of Laos PDR and the Laos National Tobacco Control Committee to conduct a research project that the overall goal of the project is to build an mHealth intervention to help patients quit smoking in Laos PDR. And as you know, smoking is the main cause of several types of cancer. And so I would like to acknowledge the NCI for funding this project. The abstract that I present today is the first part of the whole project. And in order to kind of develop the mHealth platform and the intervention, we would like to adapt our intervention messages to the Lao culture and language style and things like that. And so we did a qualitative component that we interview both smokers and healthcare providers to elicit their opinion regarding the intervention messages and other tips to help people to quit smoking in Laos PDR. So today I will present the result that we found from the interview with the healthcare professional. Next, please. So tobacco use represents a major public health in Laos PDR. 51% of adult men smoke and 7% of women smoke tobacco, not including Betel quit yet. However, there are very few tobacco cessation programs at the large scale or national scale in Laos PDR right now. And so, as I mentioned before, for this specific phase, the aim is to conduct a formative qualitative study with Lao healthcare professionals to elicit factors that help smokers quit and mechanism to improve the effectiveness of tobacco treatment programs. Next, please. So we conducted in this study, we conducted in-depth interview with 28 healthcare providers at the two hospitals, a national hospital in Laos PDR. The photo is the Sestarisat Tiras Hospital in Vientiane that we partner with. And then we use purposive sampling to select a diverse sample with regard to age, sex, work position, and specialty. All of the interviews were voice recorded and transcribed verbatim, and we used MaxQDA to analyze the data using the thematic content analysis. For cause and themes that are related to smoking cessation, we use the theoretical framework of phase-based model, the one that's specific to smoking cessation. And for cause and themes that are related to implementation and dissemination, we use the practical robust implementation and sustainability model. Next, please. So these are the results for the PPM related construct. On the right, you can see a few examples of quotes from the participants from healthcare providers. But briefly, for the in the motivation phase, the salient factors for the motivation construct in the PPM was visual education tools regarding harm of smoking, emphasis of smoking related to harms to patient, family, preparing quit smoking advice. And for the cessation phase, a critical component is medication to address craving and skill to cope with urges and strategies. For the maintenance phase, a granting follow-up to monitor patient progress is important, and advising patient repeatedly on exercising in addition to quit smoking as well. Next, please. So for the PRIMS construct, we found some important components that help facilitate the implementation and dissemination of the program in Laos as well. Like we need to continue to raise the public awareness in the mass media regarding smoking harm, and or we need to have a stricter enforcement of tobacco control policy locally. So Laos has a smoke-free environment now, but the enforcement is not strong enough. So in conclusion, this study identifies several areas for improvement to increase the likelihood of success for tobacco treatment in Laos PDR. And I'm happy to chat more in the poster session. Thank you.
Thank you, Dr. Bowie, for your interesting perspective on prevention. We're now going to move to our third topic, early detection, where we'll hear two presentations. First, we will hear from Dr. IDRIS Ola. Next slide.
Hello, everyone. I'm Idris. I'm presenting an intervention project aimed at cervical cancer early detection in Nigeria. Next slide, please. In Nigeria, the cervical cancer is the second commonest cause of cancer deaths, and is responsible for 14.8% of all cancer deaths in Nigeria, according to the World Health Organization. The most problem here is that the cervical cancer screen is low. A study estimated it to be 0.6% among the Lagos. And the key important factors are the lack of easy and sustainable access to cancer education and screening among the women. So that is the major problem that this intervention project has set out to tackle. And the aim is to increase access to cervical cancer education and screening among rural and suburban women in Lagos, Nigeria, through easy, affordable, and sustainable model. Next slide, please. So the method that we used was to create a hybrid model of opportunistic organized screening system. In opportunistic system, which is the method that has been used mostly in low-income countries, is to organize pockets of screening programs within communities. But we realize that this is not sustainable and it does not go around, and doesn't even give women the opportunity to have regular access to screening. So what we designed was to use a VIA-based technique with cryotherapy and other supportive services, but then created a cancer screening center where women have regular access to screening on a daily basis. And also we employed community health extension workers who goes into the community on a daily basis to mobilize women for screening. So they can have their screening both as an outreach within their community and also have a regular cancer center where they come in on a daily basis to have their screening and other cancer supportive services. So the model was based on strong community engagement and partnership, and also strong professional competence, which led to community health. And so we're able to also sustain the system. What we are reporting is a 9-month review and evaluation of the model, which are shown on the right, the results. Within the 9-month period, we were able to screen 13,892 women, both for breast and cervical cancer. And cervical cancer using PIA, we had 1,380 women that benefited from the services, and 181 of them had cryotherapy done. And supportive services were offered to 28 women. Indirect impact of the project has affected more than 55,000 people who are relatives of direct beneficiaries and other merchants within the community. Now, here we have a graph that showed the trend in implementing cancer education, cervical cancer education. So we can see that prior to the intervention, we had just about 13% of the women having some knowledge about cervical cancer. At the end of the 9-month review, we had more than 80% of them having strong knowledge about cervical cancer, and they were even they were sufficient enough to train other women within their community. Next slide, please. So in conclusion, our preliminary findings shows that this hybrid model increased access to an uptake of cervical cancer screening, even when the cost was attached. The provision of screening services in an organized and strategic, people-oriented manner will yield better and sustained outcomes in resource-poor settings than either opportunistic screening, which has been used in low-income settings, or screening offered only as part of routine hospital services. So this is what we have done over the last 9 months. We have simply designed an hybrid model of opportunistic and organized screening system to be able to increase access to cancer screening services for low-income women in Nigeria. Next slide, please. Okay, so these are the references to the presentation and the acknowledgements. Thank you very much for listening and for your time.
Thank you, Dr. Ola, for that great presentation. We will now hear from Derek Berry-Abila.
Yes, good morning and good afternoon, everyone. My name is Derek Abila. I'm currently a Master of Public Health student at the University of Manchester. And at the moment, I'm based in Kampala, Uganda. I'll be sharing a study about the coverage of breast cancer screening services in low and middle income countries using data from the demographic and health surveys that were conducted between 2010 and 2019. Next slide, please. So as a brief background, the cancer of the breast is one of the most common cancers diagnosed globally, according to the global count estimates of 2020. And of all the cancers, it contributes to 11.7% of the new cases of cancer diagnosed. And also it contributes greatly to the number of cancer deaths globally. And among women, it is the most diagnosed women in is the most diagnosed cancer among women in 159 countries out of 185, and also the leading cause of mortality among women diagnosed with cancer in 110 out of 185 countries. So this shows how big the burden of breast cancer is globally. And various screening methods have been used in screening for breast cancer. For example, the breast self-examination, clinical breast exam, and mammography. And currently, the World Health Organization has what we commonly call the Global Breast Cancer Initiative, with an aim of reducing the mortality associated with breast cancer by 2.5% per year. And this is estimated to save about 2.5 million lives by 2040. Next slide, please. In this study, we accessed an open access data of the demographic and health surveys. This is as a program that basically conducts population-based surveys in about over 70 low and middle-income countries. And of course, it's sad to note that very few countries incorporate questions on breast cancer screening and also screening for other cancers. So between the period of 2010 and 2019, only 18 surveys from 13 middle-income countries actually included questions about breast cancer screening. And we included a population of women that was 15 to 49 years, and the variables of interest were age of the women, where they resided, whether they resided in a rural or urban area. We also included the wealth index, and also questions about breast cancer screening, and also some of the variables we derived were, for example, that measured inequalities using what we call the slope index of inequality, which measures absolute inequalities in access to a service. And also, we also included a variable on the concentration index, which also is a relative measure of inequality. And all of these are derived from wealth index and also utilization of breast cancer screening services. Next slide, please. So in all the 18 surveys, we had a total of 342,000 women. And in terms of the screening methods that are widely used by the women, the most common screening service used was the breast self-exam. And of course, it was most common, the access, especially in the upper middle income countries compared to women who are in the lower middle income countries. Also, the next most used screening method was clinical breast exam. And still, we can see that majority of women, compared to the low middle income countries, majority of the women in upper middle income countries accessed clinical breast exam. That's an examination performed by a health worker who is trained to do the exam. And then in terms of mammography, we looked at women who are aged 40 years and above, and still you find that majority of the women who are screened with mammography reside in upper middle income countries, compared to one country that asked women whether they screened using mammography. And you still find that the level of access was less than 10% in that population. And then in terms of inequalities, you find that like in general, those women who lived in these countries and were in the highest wealth index were more likely to access the screening services compared to those who are in the lower wealth index. And this is cuts across all the screening methods from breast self-exam, mammography, and clinical breast exam. Next slide, please. So in conclusion, we find that the most used screening method in these countries was breast self-exam, and there's limited use of mammography simply because also the infrastructure for screening with the women is not well established in most of these countries. And then also there are inequalities in access to these screening services with pro-rich inequalities. And from this, we see that using open access data sets, for example, the demographic and health surveys is a very good tool to measure, for example, coverage of screening services. And I think it's something that governments could consider doing in the future, that in future demographic and health surveys, at least countries should include one or two variables that measure screening of breast cancer. And this would be very good in informing breast cancer control plans. Thank you.
Thank you both for your presentations and for your work in this area. We'll now move to our fourth topic, treatment. We will have 3 presentations in this topic area. We'll first hear from Dr. Mary Nyangasi. Next slide.
So thank you. Good afternoon and good morning. My name is Dr. Mary Nyangasi. I head the National Cancer Control Program in Kenya, and I'll be taking you through improving access to cancer treatment through establishment of regional cancer centers. I'll be explaining the key processes, the inputs, and the lessons learned. Next slide. So, of course, we are aware of the rising cancer burden. In Kenya here, it's the third leading cause of deaths. We see estimates of about 42,116 cases every year with 27,000 deaths. Majority of cancer patients in Kenya are diagnosed in advanced stages. And the background of this project was that for 50 years, treatment services were limited to one national referral hospital providing comprehensive services. And hence we undertook an initiative to decentralize care in the spirit of universal health coverage for cancer. So we document the processes, the inputs, and the lessons learned in this project. Next slide. So in the decentralization, we started this work in 2019, and we adopted what we call a hub and spoke model, where the national referral hospitals are the designated hubs, and the regional cancer centers then are the spokes. So the thought behind it was that the spokes begin providing chemotherapy services and incrementally radiotherapy services as funding becomes available and human resource capacity. So we purposefully selected the regional centers based on the existing infrastructural capacity, the cancer burden, and even the distribution of cancer cases. And these regional centers are actually expected to lead development of what we call regional systems of cancer care, ranging from very complex to basic interventions and community-based care. So we were able to equip these facilities, the regional centers, with equipment for chemotherapy, that's biosafety cabinet, chemotherapy chairs, and even gave them medicines to start providing services and technical support to hire appropriate staff. And also we were able to train them on safe chemotherapy administration so that they provide these services safely. Next slide. So what have we observed in 2021? I'll be sharing with you what our data reads for 2021. We have recorded about 84,000 total patient visits in that year, with 12,600 new patients and 71,000 follow-ups. Most of these patients are female patients, and majority are between the ages of 40 to 49 years of age. Again, we are seeing in these regional centers, 73% of all patients presenting in stage 3 and 4. At the regional sites, we had about 27,000 patient treatments provided, with majority attending for chemotherapy, and other patients also attending for surgery and other treatments like radioiodine, accounting for a few other patients. Next slide. So in conclusion, we have demonstrated a marked increase in access to chemotherapy and palliative care services. And in fact, there has been a 122nd to 126% rise in number of patients seen when we look at data from our National Health Insurance Fund for cancer patients. They have seen a high number of patients who have been seen in the last 2 to 3 years. Majority are female patients. Again, we see cancer being a major contributor to premature mortality because most patients are between the ages of 40 to 49 years, and the late stage presentation compares well with our National Cancer Registry data and even the data in the GlobalCan. Also, we are in the process of equipping the three of these centers to begin providing radiotherapy. And so in conclusion, we want to say that we have managed to demonstrate that this centralization of treatment actually will achieve closing the care gap, but it requires bold initiatives, innovative strategies that will reduce inequalities in cancer care and have greatest impact. Next slide. So thank you.
Thank you, Dr. Nyangasi. We will now hear from Emma Ju.
Hello, everybody. Thank you for coming. My name is Emma Ju from the Johns Hopkins Bloomberg School of Public Health, and I will be talking about the implementation. Oh, sorry, can we go one slide backwards, please? Oh, backwards. Thank you. So my name is Emma Ju from the Johns Hopkins Bloomberg School of Public Health, and I will be talking about the implementation of a breast cancer specific multidisciplinary tumor board to improve treatment planning and completion, funded by Susan G. Komen in partnership with Bugando Medical Center in Mwanza, Tanzania. And here in the background is a picture of beautiful Lake Victoria from Mwanza. Next slide, please. So Bugando Medical Center is a tertiary referral hospital and zonal hospital, which is the highest level hospital in the Tanzanian healthcare system. And it is one of 3 cancer treatment centers in all of Tanzania and serves a population of 15 million with high breast cancer mortality rates. So in 2016, Tanzania started developing their first service delivery guidelines for the early detection of breast cancer. And in response to these new guidelines, the Time to Act study was born. The primary intervention of the study was to create a standardized clinical pathway that included more diagnostics with the implementation of a breast cancer specific multidisciplinary tumor board for comprehensive care planning for women with breast cancer, as it is an evidence-based strategy shown to improve quality of treatment. And in this figure, we outline the pathway of how women get through the hospital system. And at the very end, boxed in red, we can see where the tumor board fits into the system. Next slide, please. The breast cancer specific tumor board was implemented in February 2020 after working with key stakeholders and selecting a key physician to lead, prepare, and guide the meetings. So once patient aged 18 and older received appropriate diagnostic tests, these results were brought to the meetings for a collaborative review, resulting in a treatment planning form created for each discussed patient. And to evaluate the tumor boards, a standardized observational checklist was completed by a research associate at each of the meetings. A prospective breast cancer registry was created to follow the patients through the pathway, and a provider survey was conducted 3 months post-implementation to assess provider perspectives on the entire tumor board process. Next slide, please. So using the re-aim metrics for implementation success, we found that under adoption, the tumor board was implemented for 18 months from February 2020 to August 2021, although they have continued past that date and we have ongoing data collection. And these meetings took over a period of 33 biweekly meetings, each averaging around an hour, with an average of 14 attendees who were doctors and residents from 6 different clinical specialties. And for the reach of the tumor boards, we see that during this time frame, we had 630 patients with breast cancer concerns presenting to Bugando Medical Center. 131 of these individuals were diagnosed with breast cancer. 84 of them were discussed at the tumor board, and 72 of them received a treatment plan. And after extended follow-up to February 2022, we see that the number of individuals discussed at tumor board went down to 46%. Due to ongoing impacts of COVID-19 and major political events in Tanzania. Next slide, please. And lastly, under acceptability, we see that providers agreed that the tumor boards improved treatment plans for breast cancer patients and that patients overall experienced improved outcomes. However, the 2 greatest challenges providers faced included not meeting before the start of patient treatment and not having enough diagnostic information. So overall, we see that the tumor board has had a positive impact on treatment planning and provider perspectives on breast cancer care at Bugando Medical Center. And our next steps will include applying stakeholder and provider feedback to improve our program and evaluating the tumor board by looking at treatment completion according to the planning forms. Thank you for listening.
Thank you, Ms. Ju. We will now hear from Sharon Gill.
Hello, everybody. Thank you for the opportunity to present today. My topic is on metronomic dosing for pancreatic cancer combination therapy that's associated with reduced neutropenia. This study was completed at the Brooklyn Cancer Center, and my mentor's name is on there. Next slide, please. So just a little bit of background. The pancreas is a digestive enzyme, a digestive organ located in the upper abdomen, and it produces an important hormone called insulin. It also produces digestive enzymes such as amylase, lipase to break down food, and the pancreatic cancers arise from both exocrine and endocrine pancreas. And I want to talk more about the pancreatic cancer patients that we had. And this presentation is going to go over a little bit of the case analysis that we did on one of the patients that I particularly handled. Next slide, please. So that I did a case analysis on. He 69-year-old patient, and he came in with a non-resectable cancer. He is currently getting treated for over 3 years, and this
Miss Scale, would you be able to turn your video off? The sound isn't clear.
Patient was initially on fulvestrant for about 3 weeks in 2019, but we saw that patient did not have any improvement, and there were no signs in Jonsson. But what we did with our strategy is weeks, and then 4 weeks, and then 6 weeks of dosing. And we saw that this really helped the patient, and not just in reducing the neutropenia that patient was initially and shrinking the tumor size. In the beginning stages of using metronome dosing strategy on our patients, we did not see any change in the size of the tumor. It did reduce neutropenia though, and patients experienced less side effects, but it did not change the size until after week 5 or week 6 of the treatment. We also showed that the patient who had a tumor hello. Next slide, please.
Sharon, unfortunately, we're having trouble hearing your presentation, and at this time, we're going to have to move to the next presentation. But we do encourage everyone to come to GatherTown after this in order to view the poster and interact with Sharon. Thank you. So we will now move on to our last topic area. Our final 3 presentations will cover the topic area of cancer control, survivorship, and outcomes research. First, you'll hear from Lebogang Mukokwe. Next slide.
Hello, everyone. My name is Lebogang, and I'll be sharing the results of our study titled Patient Socioeconomic and Cultural Factors Associated with Fidelity to Guideline Concordant Breast Cancer Therapy Delivery in Botswana. Next slide, please. According to research, there are global disparities in breast cancer survival. And in sub-Saharan Africa, the mortality to incident ratio is high. Breast cancer patients who are HIV positive experience worse survival outcomes compared to HIV negative breast cancer patients. And in Botswana, we have a high prevalence of HIV and an increasing incidence of breast cancer. We know that adherence to treatment guidelines improves quality of care and survival outcomes. However, one of our prior studies showed frequent deviations from standard of care. All of these led us to the specific aim of this study, which was to evaluate those patient socioeconomic and cultural factors associated with treatment fidelity and how this may differ for patients living with HIV. Next slide, please. For our methods, we conducted one-on-one phone interviews using semi-structured interviews of high versus low fidelity, as well as HIV positive versus HIV negative patients. Our final sample size was 30. 15 of those were high fidelity and 15 were low fidelity. And most importantly, 10 of the patients were HIV positive. Next slide. Coming to our results, we identified multiple barriers and facilitators of fidelity to guideline concordant breast cancer therapy. We organized our barriers according to the integrated behavior model, which summarizes that attitudes, perceived norm, and personal agency affect intent and behavior, and these are also influenced by knowledge and environmental constraints. Under attitudes, patients experienced feelings of shame, fear, futility, and toxicity. Under perceived control, the most common barrier was cancer fatalism and social stigma. Personal agency was overrated by environmental constraints, which were mostly related to access and health system factors. Also identified was distinguishing barriers for HIV positive patients, such as increased toxicity, parallel health care, and intersectional stigma of being diagnosed with both HIV and breast cancer. It became apparent through the findings of our study that stigma is a huge challenge for patients diagnosed with breast cancer, more especially those diagnosed with both breast cancer and HIV. We have a few illustrative quotes from some of our participants who experienced stigma, saying, "In Botswana, when people hear that you have cancer, they almost certify you dead, discriminating against you, look at you in an unpleasant way, and make references like, look at her, I hear she's been diagnosed with cancer, she's going to die soon." Another patient said, "The first day I got the results from the hospital, it was very difficult. I even started having evil thoughts, asking myself if I should stand in the middle of the road for cars to hit me." Another one said, "People die of shame and failure to accept themselves. I think living with disabilities does not mean that you are not human. Even if I may live like this without the other breast, I am human and I will continue with life." Another patient said, "The nails became black and my hands also darkened. My face looked like I had burned." So that being the case means that you become uncomfortable mixing with other people. You can't exactly go into the community with dark hands and a face that looks like it was burned. And from a patient who experienced intersectional stigma, this is what they had to say. "The challenges of HIV and cancer are that these two kill. That on its own makes one think that they're definitely going to die when they're diagnosed with HIV and cancer." Next slides, please. For our facilitator, the most prominent factor influencing treatment initiation and adherence was self-acceptance and destigmatization. Additional facilitators included peer support, anticipated management of side effects, and social support. Care integration was identified as a specific facilitator for HIV-positive patients with breast cancer. In a few of their quotes under acceptance and self-destigmatization, they said, "The children are asking why our mother had 2 breasts and now she has 1. But I explained to them that that's how they're going to see me from now on and that they should accept me so that I may also be free. Only when they've accepted me will I be free." Under peer support, they said, before I began treatment, a friend of mine referred me to see one lady who had done all the treatment. She had done chemo and radiation and is now on medication. When I saw how fit she was, I was encouraged to also start treatment. In conclusion, we identified multi-level modifiable patient and health system related factors. HIV positive patients experienced unique barriers such as intersectional stigma. COVID-19 added to the COVID-19 pandemic amplified existing barriers. And most importantly, we believe the facilitators from this study provide opportunities for multi-level implementation strategies to increase fidelity of guideline concordant therapy. Thank you for listening and good day.
Thank you, Ms. Mokokwe. We will now hear from Dr. Ivy Riano.
Next slide, thank you. Hello everyone, I am Dr. Ivy Riano. I am a hematology and oncology fellow at Dartmouth-Hitchcock Medical Center, and today I am presenting our abstract entitled Enhancing Cancer Control Through a Population-Based Cancer Registry in Cali, Colombia, Results for 20-Year Cancer Survival Trends. This is a project led by Dr. Luis Eduardo Bravo and team at the Department of Pathology in Universidad del Valle. Next slide, please. The population-based Cali Cancer Registry started in the early 60s as a research project of the Universidad del Valle in Cali, Colombia. To put you in context, Cali is the third largest city in the country with more than 2 million people. This cancer registry was designed as a tool to inform decision makers about all cancer cases for public health policies. Its purpose was also to determine population-based cancer survival, which is a measure of the overall effectiveness of the health system in dealing with cancer. So by analyzing data from a city in a middle-income country, we aim to generate further hypotheses about cancer survival that may have a national impact on cancer control. Next slide. Cancer cases were collected using the population-based Cali Cancer Registry from 1998 to 2017. We examined the survival of 9 types of cancer or group of malignancies in patients aged 15 to 99 years old, including both sexes. The 5-year net survival was estimated using the Poher-Per method, and survival analyses were calculated using the life table methods for each calendar year, age, and sex. Next slide, please. So nearly 60,000 cancer cases were available for analysis. In the table, you can see the most frequent cancer types in the 20-year period, which includes breast cancer with 20%, followed by prostate cancer in 19%, and stomach cancer in 12%. In the bar plot, you can see the 5-year net survival per 5-year period for the 9 types of cancer or group of malignancies. The green bar represents the later periods. So you can see that overall, there was a pattern of net survival improvement over years, except for cervical cancer, as you can see in the plot. Additionally, the breast cancer survival improved about 10% for the late 90s to the early 2000s, but have not changed over the last decade. We can see also that the myeloid neoplasia had the largest variation in survival, improving from 50% to 50% during the 20-year period. Lung and stomach cancer had the lowest survival rates. And when we stratify by sex, prostate cancer has the highest net survival in men, whereas thyroid cancer in women. Next slide, please. So we can conclude that survival trends have improved for almost all types of cancers over time. However, patients with cervical cancer experience no change in survival. And this is intriguing, but possible explanation could be the lack of awareness regarding the pap smear among the women, the need for effective treatments in advanced stages of cervical cancer, and or the limited access or unaffordable prices for the HPV vaccines. There are so many questions to answer, and further research needs to address those questions. Our data also show that breast cancer survival remains stable during the last decade, and this study contributes to evidence for national cancer prevention policies and the monitoring of the cancer control plan launched by the Colombian government. And this data also will provide information for the City Cancer Challenge launched by the Union for International Cancer Control. We want to thank all the people from the Cali Cancer Registry who have made possible the existence of this descriptive epidemiology source in Colombia, and we want to thank you for your attention.
Thank you, Dr. Riano. We will now hear from Dr. Daniel Osei-Fufie.
Thank you very much. Hello, everyone. I'm Dr. Daniel Osei-Fufie from Kimberley Hospital, South Africa. Next slide. I'll be presenting using ECHO model to reduce disparities in cancer care and for cancer control in low middle income countries. The Northern Cape province is the largest province in South Africa. However, it has the least resources for cancer care. Patients had to travel very long distances to access cancer care, and majority of cancers were diagnosed in late stages. One of the main reasons was due to lack of trained healthcare personnel for cancer care. Therefore, there was a need for modern, innovative training model to increase capacity. We therefore collaborated with the Project ECHO Institute, and we underwent training in the ECHO model. And we established outreach oncology clinics in the district hospitals as our spoke sites. Next slide, please. After we gained experience in the ECHO model, we also wanted to share our knowledge with the rest of Africa. So we organized an immersion training in February 2018 in conjunction with Namibia and Project ECHO Institute from the Project ECHO Institute in the University of New Mexico. Next slide, please. What were the results of this collaboration? Doctors, nurses, and community healthcare workers have been trained using the ECHO model to provide cancer care in all the district hospitals. The ECHO clinics have been expanded to include all the various cancers. Palliative care ECHO has also been launched to provide training in palliative care so that patients can receive palliative care in their own communities. During the COVID-19 era, we increased the frequency of the ECHO clinics and also used it in the tumor board meetings to assist with patient care and management. Of note is that there has been retention of staff in the rural areas to provide cancer care due to mentorship and empowerment. Next slide, please. In conclusion, the ECHO model is an effective platform to democratize knowledge and reduce disparities and inequities in cancer care and for cancer control in low and middle income countries. And during the COVID-19 era, the ECHO model was a very useful platform to assist with patient management. Thank you very much.
Thank you, Dr. Osei-Fufie, and thank you to all the presenters for these great presentations covering so many areas of the elements of cancer research and control. I'm so glad that we were able to showcase the incredible work of these researchers. Today, we heard from authors from 7 countries covering 5 areas of the cancer control continuum and highlighted the theme of this year's symposium, New Models for Global Cancer Research, Training, and Control. These presentations ranged from new technologies to improve cancer screening and treatment, new models of healthcare delivery, new approaches to understanding how socioeconomic factors affect care, and so much more. Now we invite you to join the Meet the Abstract Authors interactive poster session by using the GatherTown link in the chat and the password ASGCR 2022. You will have an opportunity to interact with authors from all 63 of this year's accepted scientific abstracts, including the 10 presenters you heard from today. We also want to apologize for the technical issues with Ms. Gill's presentation and encourage everyone to find her poster in GatherTown in room 5, poster number 9. We also encourage those chatting in the chat to continue their discussion in GatherTown. You can view all posters on the event webpage under the poster tab. We will see you all back on Zoom in 40 minutes at 10:50 a.m. Eastern Time for the Systems Thinking Scientific Panel. If you have any technical difficulties accessing GatherTown, please post a question in the chat and our colleagues will assist. Thank you.
Okay, hello everyone. Welcome back to the scientific panel, Systems Thinking Applied to Global Cancer Research. I hope you guys had a great time in GatherTown. I think once I figured out how to use it, I had a really good time and really interesting posters, and I hope that we can get back to it later into the conference. I want to start by saying that we really have been trying to be really thoughtful in the conference organizing committee to think about our theme of new models. And so what we're going to do in this scientific panel is to think about systems thinking as it's applied to global cancer research. And I'm just going to really quickly go through a round of introductions to our panelists. And then once we start to have some of our panel discussion, they can introduce a little bit more about themselves as they're giving some of the examples that we want to go through of why we might need a little bit of a different model in terms of applying systems thinking. So if the panelists could please turn on your videos. I'm going to start by introducing Dr. Doug Luke from Washington University in St. Louis in the United States. To Carolina Espina from the IARC in Lyon. Dr. Yinling Wu from the University of Malaya in Kuala Lumpur, Malaysia. Dr. Andrew Kambugo from the Infectious Disease Institute in Kampala, Uganda. And Dr. Guillermo Chantana from the International Society for Pediatric Oncology in Barcelona, Spain. Welcome to everyone. I'm really excited to get started. I think that we can go to the next slide. So what we're going to do today is to think about improving the impact in global research by embracing complexity with systems thinking. And I'm going to go ahead and say that one of our panelists, Dr. Luke, has been really instrumental in leading this area. So I'm a little bit embarrassed to come in and speak with any kind of authority. But I think that we've been thinking a lot at the Center for Global Health of how important this is going to be in terms of really trying to close the gap in cancer control globally. Next slide. So we have several ways that we want the participants to interact with us during this session. You can we're going to pose Mentimeter questions on the Zoom screen itself. And you can open a new browser on your computer or in your phone and type in www.menti.com. Type in the code that's on the Zoom screen and click submit. And you see the code up above 9777429. Respond to the questions and then they'll appear on the Zoom screen together with the others. And just please know that your responses are going to be anonymous, so don't worry. I think it's really kind of for us to get a little temperature check about where we are. Okay, so the first thing that I want to do, and I ask this question when I talk to any audience about systems thinking, is for our participants and for our panelists, in 1 or 2 words, what does systems thinking mean to you? Let's see if we get some. Great. Integrate, reality check, complexity, collective, strategic, comprehensive, interconnectedness, holistic, joined up health, WHO systems approach, a structural way to manage, up and downstream. I love these, smart people, difficulty, that's interesting, resources, communication. Yeah, I think these are all really great systems thinking, approaches or, kind of how we think about the need for systems thinking. So this is a fantastic start. And let's just go ahead to the next slide. And I'm going to start just by introducing with our panel, one of the ways that we really think about systems thinking is using this iceberg model. And, you know, what the iceberg model kind of shows is this penguin who's saying this, you know, use this tool to help you think more systemically. What we often do is we're responding to events on the ground. We're responding to the symptoms that we see and trying to come in and, you know, respond reactively to those symptoms. And what we've seen, and I think COVID has been such a really fantastic example of how this kind of reactive response is not necessarily serving us well. We need to start really applying this iceberg model in our global cancer control research to saying, well, what are the patterns of behavior? What kinds of trends are we seeing over time? Where are they different structurally over time? What kind of parts are related and how do they interact, and what is influencing patterns, and what are the mental models or assumptions and beliefs in different places in culture that shape how we design our systems and how we design our cancer control interventions. And I think these are really important things to start thinking more deeply about so that we can increase the leverage to intervene. Okay, the next slide. And the reason that this is important, and I just put this figure from Glass and McAtee in Social Science and Medicine from 2006, because it just really encapsulates that cancer incidence, mortality, and control, as well as all disease in general, represent complex adaptive systems. What I mean by complex adaptive systems is that they're made up of a large number of heterogeneous elements. Importantly, that they interact with each other, they produce emergent effects that's different than the effects would be of the individual elements. And those effects can persist over time and they adapt to changing circumstances. And this is what makes these situations complex. Next slide. And so the question that we have before us, I think in today's session is it time for us in terms of our approaches to cancer research and control to embrace complexity? Do we want to keep going down a simpler known path, but the wrong one to actually address the problematical situations that we may find ourselves in? Or do we want to say that we really are at a time where we can start thinking about complexity and do the right thing, even if it's a bit harder? Next slide. Next slide. So one of the things, and I really encourage anybody, if you want kind of a fun YouTube video, to go to the link that I have on here. Russell Akoff, who is an organizational systems thinker, had a quote that I just use a lot, because I think this is sometimes where we stand right now in our cancer control world. There's a critical distinction between doing things right and doing the right thing. We are very largely devoted to doing the wrong thing right. That's very unfortunate, because the righter you do the wrong thing, the wronger you can become. And so these are the kinds of things that we're going to think about a little bit in today's session. Next slide. And so this is a slide which just shows you that we've got different kinds of problems. We've got simple problems like baking a cake. They're easy. We can recreate the proven. You could do it by yourself. So there's low risk of failure. You have complicated problems like making a rocket. They're difficult to do. It improves what works. Risks are many, but they can manage. And if you've got the right set of skills and teams, you could do this reproducibly. So it's knowable, it's difficult, but doable. But then we also are challenged, and I think we can all see this in cancer control, particularly in a global context. We have complex challenges. And there are things like raising a child. It's iterative, it's ambiguous, the risks are not easily managed. The village is needed. We need to act collaboratively to do this, and the relationships between the actors are going to be key in making what we can consider transformational change. One of the things that's really important about complex problems is that the answers are unknowable. There's not necessarily a right answer, but there's a best fit for purpose answer to move us from a problematical situation to a less problematical situation. Next slide. And so I'm going to ask again for audience participation to say, okay, if we frame this as a problem identification from simple to complicated to complex, and so we've got a scale here. What if everybody just tries to rate the statements in Mentimeter according to your perception of whether the following are simple or more complex problems. So the first one being sequencing SARS-CoV-2 variants. Is that a simple problem or a complex problem? How about decreasing SARS-CoV-2 vaccine hesitancy? How about developing new SARS-CoV-2 mRNA vaccines? How about reducing mental health consequences of pandemic isolation? Measuring metabolic effects of a pandemic isolation? And strengthening health systems structural faults that were highlighted during the pandemic. So this is kind of something that we all are aware of. We don't have to rely on our individual cancer control mechanisms. And what you can see is that here we show that there are a range of problems moving from simple to complex, right? And you can see that some of the things that we have historically used and apply so often in global cancer control are some of the relatively simpler technological approaches that we need to address cancer control. Some of the harder things can be some of the more sociologic issues. And so I think this is a really great kind of example of how we have to match the problem with the solution and not just apply a solution to the problem. So next slide. So what we've tended to do in terms of thinking about models of science is we've used reductionism. And I think this slide and these slides that I'm going to show in the next few are from a group called Systems Innovation. And they have a really great open resource for systems thinking. But you can see the pattern here. In year one, if we look at this system and we just focus on this part and we've solved that problem, it'll be fine. And the next year, now you just got another part that's come up to be a problem. And if we just focus on that, now it'll be fine. And then in year three, it's yet another thing. And this is something that in a systems thinking language, we often refer to as fixes that fail. And I'm sure that we've all had some really, kind of frustrating examples of trying to work in the area of global cancer control and seeing these fixes that fail. And I'm going to move to the panel now and just ask for some examples. And I'll start with Dr. Espina. From your global work in the IARC, and you guys are looking very broadly, have you seen any kind of examples that would go kind of along with this idea of fixes that fail?
Hello, can you hear me well?
Yes.
Yes. Hi, everybody. Thank you so much for this invitation. I guess I should introduce myself briefly. I'm a scientist, a staff scientist at the Environment and Lifestyle Epidemiology branch at IARC, which is the cancer research organization from the WHO, from the World Health Organization based in Lyon. And I'm the principal investigator of the Latin American and the Caribbean Code Against Cancer, and leader of the World Code Against Cancer framework, which I reckon is the reason of my participation in this panel today. So to give an example, I would like to briefly explain what are these codes against cancer. It comes from the European experience. It's an educational tool for health promotion on primary and secondary prevention of cancer from the European Commission, and it has been around for more than 30 years now. Also as a political instrument of the Commission. And the aim is to improve health literacy on cancer risk and determinants and also cancer prevention interventions to the general public. So looking at this reductionist approach, sorry, excuse me, that you are talking about, I would say that the methodology that we have been applying for a while, and we are in the process of modifying some aspects of our work, is a top-down approach based on reviewing the evidence and expert assessment of this evidence and consensus in order to give this, to develop these cancer prevention recommendations. That's where I see the reductionism, as we expect that the general public will simply adopt and apply changing behaviors or uptaking screening interventions, for example, just by having a evidence-based and solid methodology to develop these recommendations. And these recommendations I mean, this approach can also be applied to any other type of guidelines or innovations. Also, the target groups like health professionals, policymakers, or organizations. We think sometimes that by just having a solid, we think of solid method, it will naturally be uptaken for these target groups that we aim to reach. I hope I answer the question.
You did. That was fantastic. And yeah, I think that we're going to talk a little bit more about these approaches that you're using from a more systems level to make sure that we're again matching the need to the purpose. And let me just move on to Dr. Kim, because I know that you have participated back at the beginning of the COVID-19 outbreak in a really interesting article. You may want to talk about something else, but I was really intrigued by the fact that you were really highlighting that you could address in Uganda with a relatively young population, direct, quarantine and other kind of pandemic responses. But it would be really important to look at the downstream consequences of those responses relative to, the situation in Uganda. So that to me would be kind of a fix that fails. You're trying to prevent one thing without thinking about the consequence of something else, and you're actually leading to worse problems than you started with. So do you want to maybe talk a little bit about the efforts that you guys did there, or anything else that you think is a good example of a fix that failed?
Great. Can I check that you can hear me?
Yes, yes, we can. Thank you.
Yeah, so very briefly, Andrew is my name. I'm a infectious disease doctor. I head an institute at Uganda's leading public university at Makerere University here. Actually, the example I'll give is malaria. We do a lot of capacity building for malaria. And I'll give a story where a specific person was picked up for training to improve malaria diagnosis. So this person is basically a microscopist. Somebody spends their time looking down a microscope to diagnose malaria, which is quite common here. And so they pick up this person, take them to a high-level, expensive training to improve their microscopy skills. And the person goes back to their duty station, and after 6 months, they go to evaluate how the training has impacted their ability to do this. And they actually find that the situation is worse. Upon further interrogation, what actually emerged is that that individual had been taken on 2 previous trainings, quite similar to the one he had. So this was the 3rd training. And so when they interrogated this further, they actually found that the people in his health center resented the fact that he went off for all these trainings, and actually deliberately frustrated his work because somehow they were only picking him for the trainings. And for me, the systems thinking lesson there is that a diagnosis for malaria starts from the clinician, the person who takes the sample to the lab, the person who helps process the sample, and the person who reports back. And there were problems in all of these, in this whole chain. And so eventually the team figured out that you needed to train the whole team to see improvements. But by selecting just the microscopist, first of all, you don't fix the problem. But secondly, you create resentment in the team about, why is it just this microscopist who's taking training? And so it needed to look at the bottom of that iceberg to see the linkages between the team members to be able to fix this. And so eventually they adopted a team training model, and this actually turned around the issue of malaria diagnosis. So I thought I would share that experience. Thank you.
Yeah, no, I think that's a perfect experience. And I think that that's something that we can all really learn from, because so much of what we do to intervene, in different areas is, we think, training. But you really do have to, if you're working as a team across, for example, a cancer continuum, you really absolutely have to train everyone to the purpose of your cancer control intervention, and then where their roles are and how they interact with each other. And I think this is a really good example of how, taking it in isolation probably won't be effective and can do exactly what you say, undermine what was otherwise a really well-intentioned intervention of training. Can I go to the next slide? So I'm going to just go through one more kind of, reductionist or model of science that can sometimes, I think, frustrate our ability to actually make good progress. And that's being very skill focused or technology focused and a little less problem focused. And so often we find that people have a skill and a technique or a tool like a hammer. They may have a method that they can use the hammer along with some other tools. But really what we want to look at in systems thinking is adapting those tools and those methods into a methodology. And the important thing is to make it appropriate, to make that set of tools appropriate to the situation. Next slide. And so linear thinking is kind of doing the wrong thing right, as we say, right? You have a tool, you may use that tool exactly as you should. So in the example that Dr. Kambuga just made, the microscopist learned how to do his job very well. He was good at the skill that he was trained, but we weren't tackling the right problem with that tool because the problem was much more structural. So I'm going to again open this to the panel and ask Dr. Wu, have you had some examples of kind of trying to, use a tool and you can do that in the right way, but it's not actually addressing the problem that you have? And I know you've got a lot of experience with cervical cancer screening in Malaysia, and so maybe you can relate that to some experience you've had.
Thank you, Patty. So I'm Yin Ling. I'm a gynecological oncologist. So I'm going to use two examples from cervical cancer management. So I'm a surgeon and an oncologist. So typically when we see a patient, we say, right, you have a growth, you cut it out, and then you give this chemo, you follow guidelines. But then if you use systems thinking or complex thinking and look into the big picture, you'll say, oh, what are the side effects? What are the women's perception to the treatment you've given them? Their fertility issues, the financial impact, their relationships, their jobs. So when you take into account all that, even as a surgeon, a simple surgery or simple chemo becomes very complex, in which you should be taking all that into account. So the guidelines that we follow may be a tool, but it doesn't take into account the bigger picture. And when it comes to screening, we now have a very important, a game changer. We're moving away from pap smears to HPV testing. And it's so radical that we don't even need a doctor to perform a pelvic examination to do a pap smear, but a test that's now similar to COVID, where you use a swab. A woman can take her own swab and have an HPV PCR testing, and that's simpler, more accurate, and less tests in a lifetime. So we've got a tool, HPV testing. Now, how do we make sure that the woman understands what this tool is about? Because for many people, for example, HPV might equate to HIV. What is the stigma? Do we understand what their understanding of the test is? And after they have a test done, how do we ensure that they can have care? Then we start thinking about logistics. So it becomes a much more complex picture, from thinking about affordability, logistics, stigma, perception, linkage to care. How prepared are the doctors to adopt this new test altogether, new screening method? So it becomes so big that you really have to dissect it down to little segments to see how you can step change and try and come up with a solution that may not be perfect, but it's constantly changing, and you have to be agile. And so the HPV test came about, the recommendations came about before COVID came about. And so COVID has sort of enabled PCR explanation to be made simpler, self-testing to be made more acceptable, community screening a bit more acceptable. So I think it's a great example to discuss as linear thinking, as systems thinking, as opposed to linear thinking.
Okay, well, hello from St. Louis. Good morning, good afternoon, good evening, wherever you're at in the world. I'm Doug Luke. and I've been a public health policy researcher most of my career. And this example of using the right tool for the job is, I think, critically important for systems thinking. So not only is linear thinking, as we've seen in the examples, linear thinking is a problem, but part of this is aligning your methods with your questions. And okay, are we back?
Yeah, but please keep going. Yes, thank you. Yeah, please keep going.
I'll keep this very short and just say, in the Glass and McAtee slide earlier, we saw an example of where complex systems don't match the assumptions of traditional tools, traditional linear thinking, or not just normality, but heterogeneity, multi-level dynamics. And so basically, if you're wanting to treat a system as a system or study a system as a system, the tools that you should be using are those tools that align with those much more complex underlying assumptions. Systems are heterogeneous. Systems are dynamic. They're feedback loops. They play out over time. And so maybe we'll get to some other examples, but in a review I've done in both psychology as well as implementation science, even though our frameworks support systems thinking, we still end up doing regression analyses or ANOVAs or risk or odds ratio analyses. So our thinking is systems oriented, but our tools, we still use those old tools, and that's a problem.
Great, yes, so thank you. Can everybody hear me again? So yeah, so this was a total systems challenge that we just experienced in real time. So I am now actually Patty Gravitt under the pseudonym Mishka Kolisira. Nice person to be, so if there was anyone, and I thank her for rescuing me. I don't know what happened. Yeah, so I think these are two great examples, and I think maybe we can move on to the next slide just for time. And I think that Doug just captured this, that sometimes we really want to think about doing the right thing right, and that's going to include systems thinking. And it is adopting different tools and approaches, as he just said, because one of the things that's striking, and if we go on to the next slide, is that some of the tools that we use for analytic thinking, and I want to just pause here to say that, you know, analytical thinking is still in biomedical research a foundationally important approach. So we're not at all saying to abandon it. But what we're saying is that it is looking at things in terms of more basic building blocks. It's good for understanding the how and understanding the inner workings of increasing efficiency of parts. And so we can think about this in terms of the things that Dr. Luke just said: randomized controlled trials, controlled in vitro experimentation, biostatistical generalized linear models. I think that's one of the interesting things, is that if you really think about epidemiologic analytic approaches, they are all linear. So they don't allow for the real analysis of feedback loops and things like that. So next question, or next slide. And so I just wanted to frame that, because when we talk about systems thinking, we're always going to be talking about approaches and making trade-offs, and they're problem-centric. And so one of the things before I got cut off that I was going to say in response to Dr. Wu's example is that, you know, it's really about matching the work to the problematical situation. And we're never going to solve complex problems to make them irrelevant, but we will improve them over time. And because things change, we may need to apply different strategies over time and adapt continuously, as we just saw. And so the RCTs and other quasi-experimental designs are concerned with internal validity and precise measurement. And in those examples, often noise and complexity is considered the enemy. We want to control that. And in a systems thinking approach, the desired precision and control, or sorry, in the reductionist approach, that precision and control will limit the ability to measure and understand real world effects that are due to adaptive complex contexts and ecology. So next slide. So one of the things to go into the second half of our presentation is, are you familiar with any of the tools that we have listed here to use to understand the why? So systems dynamics, people can just vote. Group model building, network analysis, soft systems methodology, agent-based modeling. Great, we'll keep going. So a lot who are familiar with network analysis, system dynamics, group model building. So these are kind of some of the hard systems that people are familiar with. Soft systems methodology being much more as it's described as soft system, which kind of helps us to understand the problem situation itself. Okay, I think we can stop the voting and move on to the next slide. So those are some examples. Does anybody else have any other examples about tools that you've used in systems thinking? And our panelists can maybe share if anybody else has used any other kind of tools or methodologies. Group discussions, great. Interactive dashboards for stakeholders, really important. Open-ended surveys. Great. Okay, so for time, I'm just going to move on. Community-based participatory research, machine learning, GIS tools. Yes, perfect. All disciplines tumor boards. Great. Okay. Let's go ahead and stop the Mentimeter and go on to the next slide so that we can really start talking more about these tools and how they're used in a holistic thinking so that we can, again, understand the why, understand how things happen in a context and why the approaches or what happens changes according to context so that we can improve the system coordination, as I think we've had good examples for so far, and make transformational change. And so if we could go on to the next slide. So I can remind myself. Oh, okay, go back one. We'll end with this one. So let's now just break it out into the panel. And Dr. Chantana, I'll start with you. Are there any kinds of systems thinking approaches that you found to be really important in some of your cancer control work? Particularly, I know you're working a lot in the area of pediatric cancers.
Yeah, thank you very much. In fact, I'm a pediatric oncologist. And yes, I kept thinking on the story of ALL, of acute lymphoblastic leukemia, for example, which is the most common pediatric tumor that is highly curable in high-income countries with relatively high-intensity chemotherapy. And when we try to do the same, so I really like the term that we are using the wrong tool. We try to replicate the results in low and middle income countries with these treatments. And then we realized the results were not the same. And so we have to think about the systems and why this didn't happen. It was not because the drug was different. We were using the same treatments for treating the same disease, but there were a lot of other topics that we were not considering. For example, socioeconomical issues about abandonment, tolerance of the patients or the families for the treatment. The hospitals themselves, sometimes they didn't have the capacity of managing the toxicity. So doing what we thought it was right was doing what in fact was wrong. And then we read new papers and said, we have to increase the dose. So when we increase the dose, we have more mortality and the results were lower. So it took years for the pediatric oncology community to think on the systems, on things on adapting the treatments to the local capacities, and at the same time building local capacity just for the low and middle income countries to be able to provide better treatments for the patients. I think that is, in my experience, is probably the clearest example in my discipline.
Yes, that's a perfect example. I really appreciate that. And I'm wondering, because you mentioned it took a while for, because sometimes we do need to bring in the international community with regard to, guidelines and, best clinical practices. but they don't often involve complexity or context specificity towards the guideline development. And so maybe I can move on. So Dr. Carolina, can you maybe talk a little bit, because you're working with IARC, you guys do a lot of guideline development. Given these examples of how the guidelines don't always translate to different contexts, do you know of certain things that could be done, or is there anything IARC or other international agencies you think are doing to try to address this challenge?
So I can address what we are trying to do within the umbrella framework of World Codes Against Cancer. As I said, the existing experience is the European one, and now we are adapting it to other regions of the world, starting with Latin America and the Caribbean. And I guess my example is a pragmatic approach, because we don't have a solid or established methodology to incorporate all these new system thinking elements from the start, but we are adding elements on the go, let's say. So we are trying to include implementation and dissemination research frameworks for part of the project, for example, to improve dissemination efforts once the code is out there. We are doing some formative research on how policymakers and health managers, in this case in Latin America, would see such a code for their reality in their countries, in health systems, and how they could implement it. We are trying to include participatory approaches with the general public. This is something that we are going to do in the next, or trying to do in the next European code. And for that, we need to apply mixed methods, and the qualitative research is very important in this sense. We would like to have the feedback on the general public on previous edition of the codes, and how to improve it for the future editions, those recommendations that in principle are targeted to them, but also the dissemination channels, how we should deliver this knowledge for them to adopt the recommendations, apply it in their lives.
Right, great. Thanks so much, Dr. Espina. And Dr. Kumbuka, I'm sure you probably have a lot of examples from Uganda of also kind of realizing that some of the kind of accepted standards of care from a Western perspective are not always working in a general context for all of these similar kinds of, propagating systemic and contextual issues. Can you give us some examples of how you've dealt with that in terms of trying to get international communities to be a little bit more, kind of realistic about how we need to adapt our interventions to context to make the highest impact, because ultimately that's what we're trying to do. Dr. Kumbuka?
Can you hear me now? Oh, thank you very much. Yeah, I know that this is an oncology meeting, but I think if I cite an example from the infectious disease world, it will still make sense. I know there are a lot of infection-related malignancies. So let me give an example from HIV programming. We have many tools, biomedical tools that prevent HIV. You have condoms, you have antiretroviral drugs themselves as prevention, you have circumcision, right? And in this part of the world, a lot of young women acquire HIV at high rates compared to their male counterparts. And it's very easy to try and give them these biomedical tools, give them access to condoms and all these kind of things. But actually, many of the drivers of HIV acquisition in young women are structural. And so you find economic pressures, societal pressures, and a lot of young women getting into what you call transactional sex. So in the HIV programming world, we've learned that it's not enough to provide these biomedical tools. It's important to empower young women, increase their thresholds to resist pressure, but also give them incentives and avenues for them to improve their own economic outlook as a way for them to be resilient. And so something that people can Google up is a program called DREAMS that targets young women. and enables them to build resilience so that if they are faced with pressure, they can protect themselves from HIV. I hope that example kind of rings a bell with the audience. Thank you.
Yes, thank you, Dr. Kambugu. And I think that, one thing that we also should be mindful of in terms of the system is we're a system of international scientists and people who are concerned with the health and well-being of our communities across the world. And to that extent, we don't need to silo ourselves just into whether we're oncologists or we're infectious disease specialists, because the kind of systems strategies that we can find out which works to intervene in these kind of complex situations are really transferable, right? So if we think about generalizability, there's middle range principles that could be generalized, and I think learning from each other should be really helpful. Dr. Luke, maybe you want to expand on some of this, because I know that you were really involved, for example, in the tobacco control strategy using a systems approach for global tobacco control. And you may have other good examples, but just, how can we better start using these kinds of tools as we move forward?
Thanks, Patty. And this is such a great session. Really, really happy to be part of it. Tobacco control. So I'll just say a couple things which refer back to. Well, I'll just give an example that is a sort of a classic example in tobacco control in policy research. So we've known for a long time that the best way to reduce cancer and other bad health outcomes from tobacco use is, prevent kids in particular from starting to use these products. And so there's been a lot of policy work over the decades. And one of the most effective ways is to raise prices. In the United States, that's through taxation. But if you make products expensive, it reduces initiation and downstream health outcomes. I think we all know this. What's interesting is a lot of the early policy work was this highly controlled and or economic sort of modeling where we would come up with what's the elasticity, how much do you have to raise the price of a pack of cigarettes to get behavior change. And what turns out is when communities would implement these policies, the effects in the real world were never quite as large as seen in these highly controlled studies. And the reason was quite simple. These highly controlled studies ignored the tobacco industry. So, as soon as a policy was adopted in San Francisco or New York or wherever, the industry would be there to say, okay, you can, let's have this policy as you suggested, but let's grandfather it in. And so it only applies fully after 10 years. Well, of course, when you weaken the policy like that, it's not going to have the effects. So that slide you showed earlier about looking at the one node in the network, that's what a lot of policy research would do. And so as soon as we take a more complex systems approach, there's a great quote that, in policy work, you always worry about unintended consequences. What's the unintended consequence if you adopt this policy? Well, systems thinkers, I think this came from Joshua Epstein, but there's a great quote: there are no unintended consequences. There are just consequences. And systems modeling allows you to bring more of those parts of the whole system into your modeling, so you're not surprised when parts of the system react to an intervention in that system. So we could, anyway, that's just one example, but I think it's a good example of why these systems thinkings and approaches are so important.
Exactly, because there, and it comes down to the fact that there's an intended purpose of a system, right? So in what you just described, the intended purpose being to reduce, initiation of tobacco use among kids, right? But there are so many different actors who interact with each other in ways that we always can't control. But if we can understand them better and learn how and where we've got the leverage to mitigate some of the consequences we might anticipate, and then maybe intervene at multiple high leverage points simultaneously may have a much better outcome, right? Because again, they could be more than the sum of their parts. So the overall effect could be much greater than any RCT, you know, or policy kind of analysis that's just looking at one in and of itself, right? So I think that's really important. And Yinling, I'm going to go to you again because I know that some of the things that have been, you know, the struggles that Dr. Luke just presented in tobacco control with regard to the variety of stakeholders and the interests that have to be attended to when you're thinking about making a change. And let's just come back to the example that you used before, where we have this, we have now this really great evidence-based tool of HPV testing with self-sampling, and it opens up all kinds of possibilities. But do you want to maybe talk about some of the structural barriers that you've been encountering in Malaysia, of how just having that tool is not enough, that we have to attend to all, you know, many other structural problems in order to make that intervention realize its potential? And I know this is sometimes asking something that's a little politically sensitive, but just in a broad sense, kind of who are the players? Because one of the things that I always try to say when we have these conversations is everybody has their own stakeholders and their own mandates. And so industry do have to react to their shareholders. So they have a purpose of their system. And that's just that sometimes the purpose of their system is not in alignment with the purpose of our system of cancer control. But, you know, working in a systems way, we can understand where we can find that compromise and those leverage points. So maybe you can talk about, you know, some of those system stakeholder challenges that we need to find ways to attend to in order to advance cervical cancer screening, for example.
Thanks, Dee. I think thinking about the process of cervical screening has been most humbling. I've had to meet individuals with other professional skills, people who are good at telco, lawyers who deal with data, the infrastructure of transportation. These are people I would have never met in my medical training per se. I would have met people in the science laboratory. But when you talk about digital tools, mobile technology, and how it's the usability, those are skills that I've never been brought up to train, and I would never be able to be an expert in that. So when you start constructing these systems and you start thinking about solutions, you really have to start bringing in experts that you traditionally, conventionally do not work with. So over the last year, I've spoken to financial institutions about reimbursements. I mean, I don't even know how to balance books, but I have to talk to people about scalability of the finances and looking at business plans. Gosh, you know, so these are examples when it comes to, you know, guidelines, HPV testing, positive referrals. But when you break it down to systems, you look at data management. What is an individual's data from the community? How do you transfer it to the hospital? Something like that is so complex and can be a deal breaker when it comes to something as simple as screening.
I agree. And I think we're all realizing that challenge as we move from the kind of discovery and the technical innovation phase to the implementation phase. And this is one of the reasons I think in an implementation research perspective that systems thinking is going to be so critical. I'm going to open it up to the panel now to kind of respond to that, because what that's really bringing up is that we don't always have the means to bring these very diverse stakeholders together to work as a team to try to understand our systems against our purpose. And does anybody have some examples of how you managed to get that together? Could you guys hear me? Yeah, anybody want to give, okay, anybody want to give a start to that? Kind of examples of how you've managed to bring a broader spectrum of stakeholders, you know, just beyond your oncology community together to try to talk about this?
I'll just start. So I'm not an oncologist, but one of the things is we started putting community stakeholder activities into our aims in our grants when we specifically we started putting D&I aims in our research studies. NCI has been seems to like it. And because part of it is if we don't put it in our grants and put it in the budget line, it's less likely to happen. And that way, from day one, we're able to have, for example, a community advisory board that meets more than just once a year and rubber stamps things that are actually an integral part of our work. So that's just one example to get us going.
Somebody else have an example of how you've brought together different stakeholders across the system to try to find ways to address kind of an urgent challenge. And I'm also going to put it out there. I imagine that may have had to happen during pandemic circumstances for all of you as you tried to continue doing your work under some very rapidly evolving contextual situations.
If I may react, sorry.
Oh, go ahead, Dr. Espina.
It's not related to the pandemic situation, but the way we put together our project is involving a lot of experts, between 60 and 80 experts, not only in cancer prevention, epidemiology, etc., but now also in cancer policies or NCD policies, and working groups of experts specifically on behavioral science, communication, psychologists to help digest these recommendations, which are based on the evidence, but we really want to make the public to engage with them. And also we engage from the start to the disseminators and advocacy key players that would be actually advising along the process, and they are the recipients of the final product and the ones that are going to facilitate the dissemination.
That's great. So that's a really important kind of example of bringing multiple disciplines into kind of our cancer control objectives, which I think is super critical. Dr. Kambuga, did you also have a comment to make on this point?
Yes, I just wanted to share our experience with COVID-19. So before COVID, I've been part of a number of collaborations, including some what you call North-South collaborations, specifically with the University of Zurich. And we used to really talk about what are called One Health approaches, which is really part of systems thinking, because in One Health, you try to move out of the boundaries of human health and think about animal health and environmental health. And we used to have these annual symposia looking at One Health and talking about why we need to address it. But I can tell you, after a few years, we felt as if we're hitting a wall. And to some extent, you could think that we were being alarmist, talking about pandemics. Now, with the emergence of COVID-19, it's been very interesting to see how not just countries, but how the global community has responded to COVID-19. But if I can restrict my submission to Uganda, it's just amazing how COVID-19 has brought together actors who normally don't talk to each other. I mean, I can cite the example of the tourism industry and the medical establishment and immigration. I mean, it's just, you know, I've had the opportunity to go to national level task force meetings and just to see who's in the room and thinking back that this was unthinkable 2 years ago. So it's just unfortunate that sometimes it takes shocks like pandemics to cause people to talk together to find a solution, because in the end, people realize that they have skin in the game and they have to work together. So it's very interesting to see how the post-COVID world will affect systems thinking, actually. Thank you.
That's a really, really great comment. And I think that one of the things that, you know, I kind of was thinking this is some, you know, ironic positive emergence of the pandemic is that we would learn more kind of because we all experience the interconnectedness that we all have. And I think that one of the challenges that maybe we can end with a comment from each of you is, how can we take this opportunity that Dr. Andrew just presented to us and make sure we don't lose this window of opportunity to move a more systems approach into our routine ways of working in terms of cancer research and control, and even more broadly in biomedical research and attacking some of our sustainable development goals in health. And I'm just going to go one at a time as I see you guys on the screen for a final comment on how you think that we might do that. Dr. Carolina.
Thank you. So to wrap up, I think we should leave more space for less traditional approaches to get into our research and evidence-based initiatives in order to translate this knowledge to implementation. I mean, for the implementation, to adapt the methodologies to taking into account the local context of where we are working.
Great, thanks so much, Dr. Ospina. Doug.
It's such a great question, and there's so many ways to respond to it. And I will, so I'm going to pick two. I was just going to pick one, but I'll pick two responses. The first is looking at the slide that's up right now. Start with the thinking, not with the methods or the tools. If you approach it by trying to understand what it is you're trying to change or what it is you're trying to improve, that can be a great guidepost. And that will help avoid the rule of the tool, you know, so that's the first thing. And the second thing, because I sit in an academic institution, I'm always thinking about our students and the next generation, and we just have to be willing to, so Carolina's suggestion about less traditional approaches, that can also start, you know, we don't have to wait to the last class to teach them network analysis. You know, we can start at the very beginning and introduce systems thinking in our training much earlier than we do now, if we ever do at all. So those are my two things.
That was great, and I completely agree. And I'm going to use the rule of the tool. So if you hear me use that, please know that I am, at least in my mind, crediting you if I forget to do it overtly. But I think you're right. I think we need to find ways to put this in a curriculum and let us be more critically thinking, and let us allow ourselves to also be wrong. I think one of the things in kind of academic research is that we've gotten to this point where we always have to have success. And sometimes it's by our failures that we learn the most. And if we can start to appreciate and embrace that, as long as we're addressing the tool in the right way, we can move forward. Oh, sorry, Dr. Guillermo, how about you?
Thank you. Yes, a great discussion. I think my 2 cents will go for the virtual tools for communication. I think that has been something that brought COVID. In fact, it was there before, of course, but I think with COVID, our experience in the pediatric oncology community, at least, was that it brought us together more quickly and very effectively. So I think virtual tools can be really helpful to involve different partners, to become in touch more often. So that would be my 2 cents for this comment.
Thank you, Dr. Chindara. And I think that, you know, what you said is one of the ways that I'm going to summarize that is we need to think about making that sense of urgency that we had to address some of our, you know, chronic disease challenges look similar in terms of how we're going to react than that we have observed for COVID. Yinling.
Well, I think we have to start getting uncomfortable, getting out of our usual comfort zones, whether it's a university or hospital, to feel the pulse of the people that we're trying to help, to have an empathetic approach to the community. And the systems will be different for these different communities, even in the setup in Kuala Lumpur, where a rural community, the urban rich, the urban poor, you really have to have a feel of what it is to ensure that the systems that we are trying to work out works for this. It's an empathetic approach, but getting really uncomfortable with our own comfort zone.
Thanks, Yinling. And you know, one of the things that I think you and I have spoken about in the past is we need to redefine who the experts are. I think because often in some of these systems solutions, the experts are not the ones who are sitting in an academic ivory tower. The experts are the ones on the ground innovating every day to try to better the health of their communities. And we need to learn how to engage those innovators more in our biomedical research community. And Andrew, I'm going to let you kind of close us out with how do you think that we can capitalize on the urgency and the approach of using systems thinking and bringing people together, as you so eloquently described. How can we make sure that that doesn't end and we go back to the
First of all, I've really benefited a lot from listening to my fellow panelists, including Dr. Wu's last statement about empathy. It's very insightful. Like Doug, I am based at a university, and what is striking is that a university is cross-disciplinary, but when you talk to graduate students, they're doing more reductionist work, if you see what I mean. And it's a real tragedy that the arts are not talking to the sciences and the medical sciences are not talking to the social sciences. So the thought that I want to depart on is, could we sponsor more programs at graduate level that are systems thinking driven and lend some glamour to those programs? Because right now it's people who are doing very linear work in a lab, you know, get all the kudos. And yet it is possible that graduate students who do systems thinking work might have more impact. So can we build those programs that attract the best talent as well for systems thinking? Thank you.
That was wonderful, and it's such a great sentiment to end the panel on. Before I move to the final slide, I really want to thank this panel for such really inspiring and insightful comments. This has been so much fun for me. I couldn't have asked for something better. And just to end up, if Doug, you can advance to the last slide. So I just wanted to leave us all with a couple of quotes from Greenhagen Paltzy, I'm not sure if I'm pronouncing your name correctly, about the way forward. And this is inspiration from a paper that they wrote in BMC Medicine from a 2017 workshop, We Need to Talk About Complexity. And that quote is that as researchers, clinicians, and lifelong learners, we need to develop capability and capacity to handle the unknown, the uncertain, the unpredictable, and the emergent. In other words, we need to develop a systems mindset. And in complexity, science will not provide a simple fix for the inherent tensions and paradoxes in contemporary health systems. We understand that, but it will allow us to focus on and begin to research uncomfortable knowledge, to negotiate good compromises, and to embrace creative, reflexive, and collaborative ways of working and thinking. And I think that what came out of 2017 workshop has just been reiterated so nicely today by this panel in 2022, that to me says that we really need to work together as a field to advance these methods of thinking. And so with that, I am going to again thank everyone for attending this. Please, as we're leaving, in 1 or 2 words with Menti, come back to our original question. After you've heard this, what does systems thinking mean to you? And while you're responding to that Mentimeter question, I'm going to, again, thank you and pass this off to Dr. Karina Muchuru and Dr. Sam Feary for day 1 closing remarks. Again, I really appreciate your attention. This was so much fun. Thanks so much. And now to Karina and Sam.
So thank you, and as already said, I'm Sam Feary, Programs Director at Partners in Hope in Malawi. And I will be co-hosting with my colleague who will introduce herself in a moment. But at this time, I would like to thank you all for joining day one and of the 10th Annual Symposium on Global Cancer Research. Today, we will see a stellar component of the program, which looked at the highlights, which I would mention that we had the oral abstract flash talks by 10 presenters from 7 countries on studies addressing cancer-specific interventions, prevention measures, socioeconomic inequalities, and also health disparities. And we had also a chance to have a highly interactive Meet the Abstract Authors poster session, which we was really quite great. And as we're finishing just now, we had this stellar scientific panel discussion, which was focusing on demystifying and discussing practical application of systems thinking in global cancer research, as shared by our esteemed panel, and also inputs from our attendees. And I'll pass on to my co-host as we move to the next slide.
Thanks everyone for attending. I'm Karina Mustro. I'm Associate Professor at the University of California, Los Angeles, co-hosting with my colleague, Sam Peary. Thanks again for coming today. We hope to see many, if not all of you tomorrow for day 2. Here's the agenda for day 2. We begin with a brief recap from day 1, and we move into our second scientific panel. This time the focus is on rethinking academic global cancer research. That's followed by a second Meet the Abstract Authors interactive poster session. And then lastly, we'll have the presentation of the Rachel Perline Award and the keynote address before closing remarks. Next slide, please. Next slide. Thanks. If you won't be with us tomorrow for the symposium, please take a few minutes to fill out this anonymous survey. The inputs from the survey are used to evaluate the symposium and make improvements in the future. You can scan the QR code on your screen. There's a link in the slides, and it was just shared in the chat as well. Next slide, please.
Next slide, please. So at this point in time, we would like to thank you for joining us, and we will see you tomorrow as we continue the program.